Floor, the penthouse.
Okay, let's get started. Welcome everybody to the launch of the Global State of Harm Reduction 2018. My name is Naomi Berkshire. I'm the Executive Director of Harm Reduction International, and we're very pleased to have you here today for the launch of our exciting Global Tracking Report. We're particularly honoured to have Kun Mayarutchat Pansutat here today from the Thai Office of Narcotic Control Board, as well as Dr. Passakorn from the Ministry of Public Health. Thank you so much for joining us with your colleagues from ONCB. Also delighted to be here with Daniel from the Global Program on Drug Policy and Development. I've been using that acronym too frequently. Our good friends at the International Drug Policy Consortium, UNAIDS, ANPUD, and colleagues from UNODC. I will hand over to Kun Mayarutchat to open the event with words from the Office of Narcotics Control Board. Thank you so much.
Thank you, Kunami. Kunami Burger-Shiner, Executive Director of Harm Reduction International. Kun Ann Fordam, Asian Network of People Who Use Drugs. Kun Daniel Brumbacher, Head of Global Partnership on Drug Policies and Development of German Development Agency, GIZ. Kun Eamonn Murphy, Director, UNS, Regional Support Team for Asia and the Pacific. Kun Ann Fordam, International Drug Policy Consortium. Ladies and gentlemen, a very good afternoon, everyone. On behalf of Office of the Narcotics Control Board of Thailand, it's my great pleasure and honor to be a part of the launch of the 2018 Global State of Harm Reduction biennial research report on international harm reduction, which contains global data and responses to HIV, hepatitis C, and tuberculosis epidemics related to drug use. It's definitely a good source for policy makers to study and utilize as a reference for our public health-led drug control policy. As a result, from the UNGAS 2016, Thailand has seriously been considering a new paradigm of national drug control policy instead of focusing on drug suppression, which has caused problems of overcrowded prison and the quality of treatment access. The new paradigm shift emphasizes on public health-related issues, human rights approach, and treatment services, including all adverse effects to individual, family, community, and society as a whole, especially when dealing with drug users and addicts. These users and addicts are regarded as patients, not criminals, and should be treated properly and kept away from all dangers of drug use. Thailand has therefore adopted harm reduction approach, and it's more obvious in these few years. Opium addiction and injection drug users were a major problem in Thailand in 1970 and induced to the HIV AIDS among them. The distribution of clean needle and syringes has therefore been initiated since then as a pilot project in Bangkok and in some areas in the northern. Moreover, some hospitals have also provided methadone maintenance program, MMT, for those IDUs. At present, although the statistics of IDU remain low in Thailand, users are still considered as a vulnerable group who can be affected by blood-borne transmitted diseases. To address this, Thailand has applied harm reduction measures through the implementation of pilot and outreach projects in 37 provinces all over the country, covering all IDUs from every drug type in order to assess the feasibility, efficiency, effectiveness of the project in Thai context. Despite these efforts, much remains to be done. With this in mind, we would like to convey our gratitude to the government of Germany for your kind assistance in sending experts on harm reduction to share knowledge and best practices for our personnel, and also recommend us to more effectively address the problems of illicit drugs. Thailand will continue to call for enhancing partnership between all relevant stakeholders and remains committed to providing greater investment to support quality drug treatment programs. Ladies and gentlemen, the launch of the Global State of Harm Reduction 2018 today will provide us with a significant information and up-to-date statistics of world health situation related to drug use. I would like to take this opportunity to extend my sincere appreciation to the HRI for launching this invaluable report, which can be useful to every government. Last but not least, I wish to extend my heartfelt thanks to all panelists once again, and would also like to convey my gratitude to our distinguished guests for this notable afternoon. Thank you.
ขอบคุณมากนะคะคุณไม่วชาติ สวัสดีค่ะ Welcome everyone to this launch of the 6th Global State on Harm Reduction. I was just reminded, which is very exciting because I remember being around and supporting good colleagues at HRI during the production of the first Global State on Harm Reduction. An incredibly ambitious but such an important piece of work to help all of us understand how the harm reduction response globally is shifting and changing over time. So I'm going to be the moderator of this panel, and for our first panelist, we've got essentially the lead author of the report, Katie Stone, who is going to take us through some of the global highlights coming out of the report, as well as drilling down into some of the key messages for the Asia region. So Katie, you have the floor.
Thanks, Anne. And thank you, everyone. We're greatly honoured to be joined today by the Thai Office of Narcotics Control Board and the Ministry of Public Health. We're also really pleased to be joined by the Global Partnership in Drug Policies and Development, UNAIDS Pacific Regional Office, and ANPUD, and obviously IDPC. Harm reduction is such an important issue, so important that we wrote 176 pages about it. It's a holistic approach to build healthier, safer communities, and the evidence base supporting it is huge. It is based in kindness, compassion, and care, because punishment as a deterrent for drug use is not only ineffective, it is also particularly cruel. HRI has been mapping harm reduction all over the world for over a decade. The Global State, as Anne said, is the 6th report, and it's our most comprehensive yet. It now covers all drugs and is the coordinated efforts of over 100 harm reduction organisations, drug user organisations, researchers, academics, and advocates. The report would not be possible without them. So what's in the Global State this time? We cover the number of people who inject drugs and the number of people imprisoned for drug offences where that information is available. The number of needle and syringe provision sites, opioid substitution therapy, HIV, hepatitis C, and tuberculosis testing and treatment for people who use drugs in both the communities and in prisons. We look at the harm reduction response for people who use stimulants, cocaine and its derivatives, and new psychoactive substances. We look at drug checking in nightlife settings, harm reduction for women who use drugs, drug consumption rooms, the number of overdoses and the naloxone distribution in community and in prisons, and developments and regressions in funding for harm reduction. Globally, progress for harm reduction has stalled. There's been a decline in the number of countries providing needle and syringe provision from 90 in 2016 to 86 in 2018. There's been a slight increase in OST, opioid substitution therapy, going from 80 countries in 2016 to 86 in 2018. And there's also been an increase in the number of drug consumption rooms, but they're still only available in Western Europe, North America, and Oceania. The life-saving medicine that reverses an overdose, naloxone, is only available as peer distribution in 12 countries in the world. So 179 countries report injecting drug use, and naloxone is available in 12. 2 of them are in Asia, Afghanistan, and India. There's also stimulant use is increasing all over the world, and harm reduction services for this are not. And global funding for harm reduction programs is in crisis. In Asia generally, harm reduction has improved moderately since 2016. But there remains an alarming trend for increasingly punitive approaches to drugs, the most disgraceful of which can be seen in the Philippines, where extrajudicial killings are estimated to have reached 20,000. In contrast, Thailand has demonstrated leadership in law reform in 2007 by reducing penalties for drug possession, trafficking, and production, and enabling a more health-focused approach to drugs. Asia is home to an estimated 46% of the global population of people who inject drugs. But needle and syringe programs are only available in 15 of the 25 countries in the region. Syringe distribution is hugely important, and where services such as these aren't rolled out, we see HIV and hepatitis C incidents rise. 11 countries in Asia have hepatitis C prevalence among people who inject drugs over 50%. Hepatitis C is preventable. Direct-acting antivirals will treat it, yet they remain prohibitively expensive and out of reach for the many. Cost-free access to hepatitis C is available now in India, Indonesia, and Malaysia in the Asia region, and we hope next time that we report that many more countries have joined this trend. As mentioned earlier, the use of stimulants is rising, but particularly in Asia. Harm reduction for stimulant use requires a different set of approaches and is an emerging field. Myanmar is one of the few countries in the world to have formalized guidelines for stimulant harm reduction, and Indonesia is also in the process of developing similar guidelines. We have to ensure as well that in the future harm reduction services are gender sensitive. And ignore the fact I'm saying this as a woman, I say this as a scientist. The war on drugs has disproportionately affected women. 90% of women in prison in Indonesia and the Philippines are incarcerated for drug-related offences. Not only is it inhumane to remove so many women from society, from their work, from their families, but this trend for hyper-incarceration is completely and utterly unsustainable. With the withdrawal of international key donors in Asia, as in other regions, the sustainability of harm reduction will be largely contingent on domestic governments' willingness to bear financial responsibility for these programs in the future. And where might this money come from? The answer is easier than you think. 10% of money from law enforcement into harm reduction would virtually eliminate HIV. This 10% will enable governments to look after its people in a kinder and more sustainable way. We encourage governments to look at the evidence for harm reduction and surrender to compassion, kindness, and care. Thank you.
Thank you very much, Katie. So moving on to our next panelist, I have the pleasure in welcoming Daniel Brombacher. Daniel is the head of the Global Partnership for Drug Policies and Development, of which IDPC is very pleased to be a partner. And we've been collaborating on a few things around harm reduction, but in particular, several expert group meetings on harm reduction, the third of which will start tomorrow here in Bangkok. Well, actually, sorry, tonight. And also, GIZ has also been working together with Thai ONCB, collaborating on best practices in harm reduction over the last couple of years. So, Daniel, you have the floor.
Thank you very much. Anne, dear Naomi, Anne, Kun Mayurachat, Dr. Pasakorn, good to meet you again. Mr. Murphy, Mr. Gurung, Katie, ladies and gentlemen, colleagues. I'm very delighted to attend the launch of the 6th Global State of Harm Reduction report, published and organized by Harm Reduction International, as we have just heard in this very impressive presentation from Katie. This report series provides an independent analysis of the state of harm reduction worldwide and has shown to be the key resource for policymakers and researchers for many years. So we in the German government and the GIZ, we use it frequently. Very happy to have the new copy out now as a resource for the years to come. I'd like to express my sincere gratitude to Harm Reduction International, Naomi and your team for organizing this event here in Bangkok, as Thailand is one of the leading countries in Asia where the drive of public health and harm reduction has grown strongly in the area of drug policy in the last years in a very impressive way, as we have heard before. It's also a particular pleasure for us to be here with one of the most long-term partners of Germany, the ONCB, with whom we have been working closely in many fields of drug policy, not only on harm reduction, that's more recent, but also in the field of alternative development and other issues, both here in Thailand, but also abroad at the level of the Commission Narcotic Drugs in Vienna. Harm reduction is one of the 4 pillars of the German domestic drug policy, and is broadly implemented throughout the country in the fields through, as we have heard before, those examples, drug consumption rooms, OSD, NSP, drop-in centers, and a highly diverse set of low threshold programs. So Germany has quite a long-standing experience in the field of harm reduction, mostly concentrating in the field of injecting drug use, but in the past years also adapting to the growing importance of stimulant use, problematic stimulant use also in Germany. Due to our very positive experience with the approach, the German government is also committed to enhance internationally the implementation and promotion of harm reduction as an effective and evidence-driven drug policy approach. I think this is very much needed. I mean, probably our engagement could be bigger, but still the engagement as it is very much needed, as we have heard from the presentation. There are several issues highlighted in the report that are really worrisome and remarkable. So, for example, as Katie just mentioned, the stagnation of the global harm reduction response in the past 2 years, the decrease of the number of countries implementing needle and syringe exchange programs. And also what I just mentioned, what also affects Germany, the increase of problematic stimulant use. And last but not least, the ongoing funding crisis that was mentioned by Katie is, I think, is a very worrisome international development that should be addressed properly. The project I'm heading, we have heard the name before now on several occasions, is one of the means of the German government to increase the political visibility, the political weight, and evidence on harm reduction, expanding the traditional focus from injecting drug use also towards stimulant use. In the realm of health-oriented drug policy and development, we have, I think, developed a unique network of cooperation under the program I'm heading. To achieve its objective, the project cooperates closely with interested governments such as ONCB, with international organizations. UNODC is one of our partners, academia and civil society organizations, some of them who are in the room here today. And already mentioned, we are very happy to have IDPC as one of our implementing partners in the project. We also seek to enhance the available evidence on issues such as harm reduction for stimulants and feed it back into the international debate at the UN level. So let me just highlight one study that we have supported from a Dutch NGO called Mainline. It gives a global overview of the state of research on harm reduction for stimulants. It's also online. And at the expert group meeting we are going to have here in the next 2 days in Bangkok, we will also have some colleagues from Mainline there. Thailand, especially the ONCB, has been working together closely with my program to promote harm reduction responses to drug use. Yeah, we were here with 2 times in the past 2 years with expert delegations, but we have also received the Thai Minister of Justice in Berlin and took him to drug consumption rooms and to harm reduction programs in the city of Berlin and city of Leipzig. So we'll keep on our engagement with ONCB in that area, and we're very happy to see how things have evolved here. One of the results of the exchange that could be interesting for the room as well is that Germany has a medical treatment guideline for stimulant-related, methamphetamine-related disorders. I think that's quite a unique document. It's a very comprehensive, many 100 pages guideline for medical doctors how to treat methamphetamine-related disorders. And as a product of our exchange with ONCB, we have currently translating it into Thai language, and it will be, actually I got the email in the morning that it's done now. It took us very long, the experts, actually to find experts who could translate such a document into Thai language, and it's done now, and now we'll take it up with ONCB and see how to publish it here in Thailand. Ladies and gentlemen, let me thank HRI again for your impressive work in producing this report. It will help to shape the international debate on harm reduction for the years to come, and it will be key to frame the international debate within the framework of the 62nd CND to take place next year in March, Commission Narcotic Drugs, and the high-level meeting attached to it. And this will be a very important CND because it will assess global drug policy and its results in the past 10 years. So it's very important to have those insights ready on how the field of harm reduction has evolved in that time frame. Therefore, while there is no doubt there is an incredible amount of hard work in this document, Katie and your colleagues, I think the next challenge for all of us is lying right ahead. We need to overcome the stalemate in harm reduction and the funding crisis the report makes visible. We should make an effort to adapt and broaden the scope of harm reduction for stimulants and for female target populations, as we have heard from the report. And we have to relentlessly promote the international recognition of harm reduction that is still not a given fact at the UN level. Dear colleagues, dear joint panelists, ladies and gentlemen, please let me underline our commitment to jointly address those challenges with our partners from both civil society and governments in the next years to come. Thank you very much for your attention.
Thank you so much, Daniel. And, definitely to highlight that in my experience, Germany has always been a very strong leader of harm reduction at the international level, and it is almost 10 years since 2009 when Germany led a group of 27 other countries to decide that they would interpret the term related support services that appeared in the 2009 political declaration as harm reduction. And that was quite a strong political statement back in 2009. And I think you've upheld that commitment to harm reduction ever since as Germany. So that's really positive. So moving on to our next panelist, I have the pleasure to welcome Bikas Gurung. Bikas is the Program and Communications Manager at the Asian Network of People Who Use Drugs. And Bikas, you're going to give us a more regional and community perspective on harm reduction. You have the floor.
Yeah, thank you, Anne, and thank you, HRI, Naomi, and everyone from HRI, and everyone who is present here. So my role here is to present the perspective of people who use drugs, and thank you actually for this wonderful report that has actually given us some of the Asian context, especially in the ATS and everything. But I am here to talk about a little bit different thing. All the data and all the things that have been some of the progresses, some of the regresses that are happening in our region that are mentioned here. But I'm just trying to go a little bit in depth into stories, forgetting these numbers, but trying to bring some human stories, and then trying to dig a little bit into what's happening in terms of harm reduction in our region. So as the Asian Network of People Who Use Drugs, we would actually call it harm reduction under prohibition and criminalization rather than just harm reduction. And we hear a lot of times that this phrase that war on drugs has failed, but we have come to believe that maybe harm reduction also has failed in many ways, because the things that I'm trying to share here within the 4 minutes, I will try my best. So the harm reduction movement started with people who use drugs. When the needle syringe exchange programs were illegal, people were distributing syringes to their peers and then trying to support each other. And that was much more effective then. But now the way the harm reduction has evolved under the prohibition and criminalization regime, it has evolved into something that our community never wanted. Many communities have died while advocating. Many people have died due to overdose. They were advocates, they were activists, but they never dreamed of this kind of harm reduction services that we have been catered right now. So we have hardly known about heroin, while there are thousands of types of drug users we don't know about, and it's just heroin. And now we are trying to speak about ATS. We don't know. Most of us don't know, and the main reason behind this holistic failure is that these policies, these harm reductions, or whatever is being done is designed by someone who has never used drugs. He does not, or she does not know what it's like to be a drug user, what it's like to be chased, what it's like to be stay hidden, and then always be harassed or be a victim of violation of human rights. So let me just start by some of the country cases, what's happening. So I will start by Malaysia, where if a drug user is a PL-HIV or people living with HIV, then he or she cannot access ARV, which is the medicine for HIV. He or she cannot access ARV without being registered in the methadone center. There was a case in 2018 where just because of not having the registration in the OST, one of our community members had to die while he was going through the OST registration system. And there are urine testing happening, mandatory urine testing. And yesterday only I came to know that I don't know how these people have such a cruel kind of rationale where if if a person, if a drug user is tested positive while urine testing, then the punishment they get is 3 days of suspension from methadone. How cruel is that? Like, you will provide methadone to someone for years and years, and then if someone is tested positive for 1 day, then you will just suspend him or her for 3 days and then leave him or her to just face whatever difficulties, health situation he would or she would face. So in Vietnam, when I was there, I don't know why it has to be like that. The methadone centers, it's similar to a prison setting where there is a small window. I think most of the countries have that kind of setting where people who use drugs has to go there and then get the methadone from there, from a small window where the other side there are nurses and everyone trying to hide the methadone as if the drug user would just snatch and run or do something bad to the... Why can't it be like we can sit together? I am sitting here, I am a drug user, and I'm sitting here, right here, among all of us, where we can actually talk something intellectual, talk something constructive, talk something something about kindness. I consider myself as a kind person. I consider myself as someone who can love, who is being loved by my parents. So why can't every service provider or everyone do the same? It's just about showing the kindness, and these are happening. So Cambodia, I don't have to go like country by country, I guess, because tomorrow I think I'll go by country, and then the photos and videos, whatever I have, I'm going to do that. So it's just a snapshot here. Cambodia, of course, there is that, and then Nepal, India, all these compulsory detention centers. Recently, there was a video of Nepal rehab where drug users were being detained for 4 years, 10 months, and they were forced to lick their own urine. And they did not have even the chance to expose themselves to a sunlight for many, many months and years, that all their legs had swollen and then it was blue and swollen. So I don't know, like, how do we understand what these people are thinking about drug users? I don't know, like, is a drug user so bad than that people who is doing such a thing to drug user? So this is something that is happening around harm reduction services. People have fear going to the harm reduction services because there are compulsory detention centers running, private rehab centers running, who would kidnap a drug user and then detain him or her for many years without even letting them to talk to their families once. So, and there is ATS, of course. I've already told that 2 minutes, okay. I've already told that we haven't even like known much about the heroin itself, and the ATS is there, which is like creating this panic. ATS, amphetamine, is a medicine. I was recently in London, and I was sharing this with one of my friends of Portugal, where they had amphetamine prescribed by doctors to people who had attention deficiency, hyperactive disorder, so ADHD. So it is considered a medicine, and people have been using it in the history as something that would suppress their appetite suppressor, and they were using it as a medicine to reduce their weight. And out of nowhere, now people are being killed for using that same drug, which was a medicine sometime for rich people. And this should not be happening, and we don't know what is the harm reduction for these drugs really. So everywhere, the only program that ATS users are getting is either methadone, which is not really suitable, or compulsory detention for 18 months, 3 years, so which is not needed as per UNODC's evidence itself. So I think it's time to ask real questions. It's time to like start asking right questions, because we have been so long been politically correct rather than becoming effective in our work. So we have to stop this, and then we have to start asking the right questions. Don't ask about coverage of methadone, or don't ask about coverage of needle syringe programs. Just ask, do we want scaling up? Do we want coverage of this kind of services that is violating rights of people who use drugs every now and then? At least drug users would not want that. So this is the message from our community. We respect harm reduction principles. We respect the philosophy of harm reduction. But this, what's happening, the interventions, they do not in any way consider or embrace the principles of harm reduction anyway. So this should not be happening, and I think it's time to ask ourselves, like, because none of us will be able to ever guarantee that my child or your child is going to or is not going to use drugs. The only thing that you can guarantee here is you can reduce the harm if your child uses drugs. And this is not the service that you want for your child, of course. Right now, your children is not using, does not mean that whoever is using should face all these violations in the harm reduction service centers. So I think just think like a parent, think like as a friend of think like someone, think of someone you love. Do you really want your loved ones to go into these services? I would not want, and we are just trying to make this thing better. We are just trying to ensure that not my children, but your children also goes to a safe harm reduction service center, and we can do that. Drug users can really do that. We know what heroin does. We know what amphetamine does. We know what happens when someone uses yaba. We know that. If you would have that courtesy to just engage us and then ask us that how to do this, then we would surely tell you, like, we know what should be done. So as long as you don't consider someone intellectual, someone technically able, or someone as good as you, just because someone is using drugs, then yeah, I think you should consider the history where in the 80s, in the 90s, and in the period of Aristotle or everything, Galileo and everything, where each single musician, each single brilliant minds have used drugs. So I think we need to consider that. Thank you so much.
Thank you so much, Bikas, and yeah, everything you said is incredibly important and really should be at the forefront of our discussions. You really highlight the limitations and challenges of trying to implement harm reduction programs in a punitive environment where compassion isn't the primary driving goal of such programs. And I think that's incredibly important as we consider not only the coverage of harm reduction programs, but also the policy and the legal environment in which those programs are implemented. So our final speaker today, I have the pleasure of introducing Eamonn Murphy. Eamonn is the Regional Director for UNAIDS in Asia and the Pacific. And Eamonn, I think you're going to give a more regional perspective as well, but also referring to the UN targets and goals. I could be wrong, so I won't hold you to that.
Thanks very much, Ann. All respect to fellow panelists and to the many people here who have been working on harm reduction issues for a long time. Firstly, let me congratulate on the 6th edition of this report. It is critical that we have global statements like this that are bringing the latest information. I was talking just 2 weeks ago to our human rights reference group, which brings together experts from across the world. And one of the challenges for us is not having up-to-date information. How many people are incarcerated in detention centres rather than accessing services? So reports like this are critical for us, and we need more information on these issues. And one of the challenges that's been addressed by some of the other panelists. The advantage often of going last is that many things are said, and sometimes that's a disadvantage. I'll try not to repeat things, but and I should acknowledge at the outset my colleague Karen Peters from UNODC here. So in the UN, we work together on this with the World Health Organization, particularly as three key organizations addressing these issues. So it's great to be able to speak on behalf of the UN. In terms of HIV, we cannot underscore enough the impact and the intersection between drug use and HIV in our region. I've been working for more than 24 years on these issues of harm reduction, firstly in Australia with the government before I came to work with the UN. And just to remind us, the risk of acquiring HIV for someone who injects drugs is 22 times more than that for a person who does not inject drugs. And in our region, particularly, 84% of new infections are amongst what we refer to as key populations, which was mentioned by first speaker, including people who inject drugs. 1 in 7 new infections in our region each year are people who inject drugs. So we cannot dismiss it. Yet, as panelists have said before me, we're not hearing about this issue. It's gone quiet in the discussions in the region. We are hearing fear, as Bikas said, about ATS, methamphetamines, and rightly there's a lack of knowledge about it. So what is it? What's the impact? We're hearing, but we're not hearing about the programs that need to be maintained and integrated. The sustainability is a critical issue for harm reduction programs, and it's a big worry because government investments in HIV, and that's where our intersection comes for harm reduction programs, is largely in treatment, and treatment of HIV, not enough treatment for drug dependence for heroin in the form of opioid substitution therapy, though the report says there has been a slight increase, but a decrease in harm reduction, which is the primary prevention that is needed. We are seeing changing patterns of drug use across the region. We are in discussions with ASEAN. Just last week there was a meeting of SAARC countries, which is South Asia countries, to look at this issue. So to start getting, again, more discussion on this, because it's not going away. And it is changing. Indonesia reports reduction in heroin use, increase in methamphetamine use. So we still have major issues, and as Bikas said, clarity around harm reduction for methamphetamines and ATS. We need a lot more work, and it's great that the meeting over the next couple of days will be starting to address some of that as well. A couple of other things to touch on. In terms of the global targets, 2016 was mentioned. Countries in our region and globally have agreed to the targets of 90-90-90. As part of that, there's an additional 90% of people accessing prevention services. That's critical in terms of needles and syringes. PrEP for people who inject drugs is needed to be looked at. PrEP is the pre-exposure prophylaxis, where the most discussion of that is amongst men who have sex with men. But we need to be looking at how do we introduce PrEP, which is another tool where in some countries now, with crackdowns which are happening across the region against drug use, it's harder than ever to access the prevention services. So it may be another tool that we need to be looking at. Other areas in terms of laws was touched on by earlier speakers. I was in Malaysia yesterday and talking with the Minister of Health about the whole issue of decriminalisation. There is possible progress there, which will be a great example for the region if this comes forward. And the Prime Minister made very strong statement at an event yesterday about the need to re-engage in pragmatic ways as Malaysia has in the past. So we do have some positive signs, but we're also seeing very negative issues. The Philippines, Bangladesh, new laws, reactionary approaches against drug use emerging again. This is very negative. Malaysia is a classic example, if I just pick on one example, in terms of new infections. In 2007, 4,000 new infections a year, largely as a result of injecting drug use. In 2017, 300. Now, that is principally because of harm reduction and a mixed program. There's opioid substitution therapy, but there's a mix of programs. There, new infections are going up amongst sexual transmission. but they've had success. But so we can learn from examples in the region. Yet 11 countries still retain compulsory detention for drug use rather than community-based programs to help people deal with drug dependence. And as Bikas talked about and others, the evidence is clear that does not work. And so we need to see those countries shift. Some have mixed programs, but that's not nearly good enough. 15 countries still retain the death penalty. So we have a serious issue. The stigma and discrimination, and that's partly where the methamphetamines issue is making it worse again, is this fear factor of the unknown. And that's where some countries are reacting with the wrong approaches for it. The investment, if I focus in the final part, a couple of remarks. Good example of 10% of the justice or the policing budget would solve the problem for us. It's always been challenging to get money for health, and within the health budget, drugs programs are hard to fund. HIV programs are funding aspects of it, but are not comprehensive enough. And we need countries to invest in their both harm reduction, but their drug treatment programs and community-based programs, not just the supply reduction, which is all we hear about in the region of late. In terms of resources for harm reduction, globally there's a 20% funding gap for the global HIV response, but there's a 90% gap when we come to look at services for people who inject drugs. So that's critical to be addressed by countries as they're investing in our region in ARV treatment. What are they doing about prevention? We hear about universal health coverage as though that's going to be the new saviour of everything, but that's so grey and vague it could mean anything to anyone. But principally at country level, it actually means treatment services. Right? And the packages of services, unlike Thailand, where we have a very good model of a comprehensive health service for the people, it's largely talking about very narrow treatment services. So when we come to prevention services, which are critical for HIV, because we don't want to just add more and more people to treatment services each year, we have to maintain the focus on prevention. We're nowhere near enough resources for it. Global Fund needs to do more about working with its countries. Sorry, Palani, I know you're here, I'm not picking on you. And at the country level, the countries need to prioritise prevention in their proposals. We need to have prevention prioritised. The 20% is not enough, but we're not even reaching that in the proposals. There are a number of things that are going to be happening in the next year because, and this is where ATS is giving us a new opportunity to re-engage on some of these issues, because governments are worried about the impact on their communities. In ASEAN, there's an agreement for us to work with them, with UNODC and other partners, on a regional meeting around ATS. And in that, there will be discussions on the issues of HIV as part of that. So it's not the first step. We know the interplay with ATS and HIV and the increase of terms like chemsex, high sex, the rise of new infections amongst men who have sex with men in a number of our countries. Malaysia, 9% new increase in the last year, 174% in the Philippines. A lot of this is the interplay between methamphetamines and sex. And so we can't deny the issue, but we need to then work out how we're going to respond in a harm reduction approach rather than lock more people up where it's not problematic drug use, but the risks are enhanced. And this is where we need to discuss new and innovations, and I think PrEP is going to be one of those tools that we need to start exploring for injecting drug users. In Myanmar, and maybe Panay and others over the next couple of days can share some of the issues. There is talk of piloting PrEP in the north of the country, but we've seen in Kachin and now in Sagaing, where we're seeing the same issues emerging. What started as a very narrow injecting drug use epidemic and HIV is now generalizing to the population because of the lack of investment in services and prevention in particular. So we need to look at a new package of services with that. We will try and do the same with SAARC and have a regional meeting on it, but particularly in ASEAN countries, this is where we need to focus our efforts on that. So in closing, we all on the panel have the same commitments to the Sustainable Development Goals, and that's about the the quality of life of everybody, the respect for everybody and not leaving anyone behind. And people who use drugs in the HIV response are often those who are left the furthest behind. We've got to remind ourselves that if we're serious about the SDGs or universal health coverage, it's health for all and not health for some and less for others. So we need to recommit to that. And in short, support, don't punish must be not just rhetoric, but the action that we take collectively. So from the UN side, we're very pleased to be able to support, but congratulations again. This is what's needed to put the evidence out there so that we can all work together. Thank you.
Thank you so much, Eamonn, really for bringing it home and reminding us that also even within the HIV prevention space, you know, we're really having to push to ensure that harm reduction is a key part of that discussion going forward as we get prevention back on the map in general. So we have 15 minutes, just under, for some Q&A for the panelists. So I'd like to invite you to pose questions, or if you want to make a comment, or yeah, please feel free. You have these amazing panelists before you, full of knowledge. No? Oh, Pascal. Yes, go ahead.
Thank you, everyone, for your wonderful presentations, and thank you, HRI, for the Global State. I've been a regular contributor to the Global State, and I support the work that HRI and IDPC and ANPUD does in this region and beyond. I'm very glad to see the latest report. I was particularly happy to see that the report this time includes a section on sustainability and financing for harm reduction that's more expansive than in previous years. Some of the research that I've done in the past few years, specifically on financing for drug control in Thailand, shows that there's an immense amount of money invested on an annual basis. The credible evidence that I've collected shows that in 2015, for example, $3.3 billion were spent on drug control in Thailand. That's twice the size of the global funding gap for harm reduction. So there's a lot of money that is available, and even just 1% of that budget that redirected to harm reduction would amount to what, $33 million, which is 11 times more than what has been invested on an annual basis in Thailand for harm reduction. So there's immense space for us to be more savvy around the amounts that are being invested in law enforcement and redirecting those funds to support public health policies. That budget in Thailand of $3.3 billion also means that for every dollar that is invested in harm reduction, that has been invested in harm reduction over the past years, more than $1,000 has been invested to target those same people with arrest, prosecution, and incarceration rather than providing them with health services. So I think, again, there's an immense opportunity to rethink our approach, and it's not just that the global response to harm reduction is stalling, it's that the resources are going to the wrong place and doing harm rather than good. So I know many of you are working on these issues, and I think it'll be important in the coming years that we band together to support the 10 by 20 campaign and collect more evidence and map out the budgets for law enforcement. I know that HRI is investing resources in doing that mapping in Thailand and Indonesia and potentially other countries in the future. But I think this is really where we could get even more traction, more evidence to convince government to be more strategic in their allocations for harm reduction. Thank you.
Thanks, Pascal. Anyone else have a comment, question? Anna, please go ahead.
Hi. Ann. I'm HIV prevention advisor based in working for UNAIDS in Myanmar country office at the moment. First of all, congratulations on the report. It's very comprehensive and informative. My question is to the members of the affected community of people who use drugs, and it's about PrEP. Because when I asked the representatives of the Myanmar Drug User Network what do they think about PrEP, there was silence. And that's basically my question. I think, to what extent does the drug user community in the region know about PrEP? How much discussion is there, and what do you think? Maybe to Bikas.
Okay.
Thank you.
Yeah, thank you for the question. Around the PrEP, actually there has been a global consultation of people who use drugs on PrEP, and it was a consensus of people who use drugs that we would not accept PrEP or any form of other this kind of services as long as there is something much effective, much simpler. Like if it is around, the matter of HIV, then there is syringe. If it is a matter of STI and HIV through sex, then there is condoms. So, and so I'm just sharing the recommendations of that document. So, and it was also considered unethical for us to have that access to ARV while our own communities who need that ARV medicine so much are dying because of not having proper access to it. But there was one thing that the document also mentioned, which was it should be locally designed, locally based on a local need and driven by the local need. So if our communities in certain countries would think that, would collectively decide that, okay, we need PrEP, the services that has been provided to us in our country has not been enough, and we need PrEP, it might be another option for us, then that would be a local decision of the autonomous decision of that certain community. But global consensus is that as long as there is something simpler, easier, much more effective ways of doing it, it would be unethical for us to actually, I would not go. I'm not an HIV positive, but yeah, if I would be asked to go and start taking the pill, then yeah, I might not go. Instead, I would prefer to not share syringe ever, all those commitments, and I would prefer to have a healthy behavior and avoid any kind of risky behavior that would harm me or the people I love.
Thank you very much, Bikas.
Thanks, Bikas. I think have Rajiv also.
Hello, I'm Rajiv Kafle. I represent Asian Network of People Who Use Drugs, and I'm looking after the harm reduction in Asia Global Fund supported advocacy project. And I wanted to share a bit. I was infected with, I'm living with HIV for almost 20 years, and we have now like 50 different drugs that have been invented that assures me that I would not be dead very soon. I mean, I may live another 50 years or so. But, and in the same 50 years, I got infected around 1997, somewhere around 96, 97. Harm reduction programs were already there in place, luckily in my country, in Nepal. And, but still, I somehow shared needles and got infected. And I used to blame myself, like, okay, I was injecting drugs, so I got infected. Later on, now I started realizing actually it was the policymakers, the decision makers of my country, who just simply could not understand that giving out clean syringes would prevent me from getting infected. Say they even until now, when I go back home, if I want to buy a syringe, and I go to a pharmacy, I won't get a syringe without a prescription. Here in Thailand, I have lived here for 2 years, and I realized that I go to a pharmacy and they won't ask me. I just ask for a syringe and they would give me a syringe. The pharmacist would not ask me why I need this syringe and if I look like a drug user, and he should not be giving me syringe. Majority of our countries in this region, I see that there is this barrier, very basic thing like not having access. We have the knowledge as people who use drugs that we would want to use clean syringes, whereas we do not have access to that. In 2000, I was in a methadone program in Nepal, and then I had to travel to Australia for an AIDS conference, and then I went to a doctor in Australia. He wrote me a prescription for 4 days, and I said, where should I go with this prescription? He said, go to the nearest pharmacy. Whichever hotel you are staying, there is a pharmacy nearby. You go there, show this prescription, he'll give you your methadone dose. And then he gave me that. And that knowledge I already had in 2000. We have been living with this for 20 years, and yet we have not been able to make our public health experts, our governments, our leaders, policymakers, decision makers understand this very simple thing about providing it easily accessible, in an accessible manner, and so that people would not feel stigmatized, people would not feel like they are numbers, they are clients, or they are diseased person. Because if I want to go to a methadone clinic, then I would need to register myself. Now they have come up with new technologies of my biometrics, taking my biometrics and all. So I get kind of like, okay, should I give all of my information so that they would be tracking all of my movements, or should I rather just do unsafe way? Because anyways, I decided to do this for myself. It's my body, you know. So I wanted to ask this extreme panel, like, why are these such a simple concepts of giving clean syringes or a substitution to someone not being able to replicate in other countries, whereas we have this knowledge for almost 2 decades now?
Thanks very much, Rajiv. So we're running out of time quickly. I saw Palani, if you can say it in very short, in a minute or less, and then I'll come back to the panel very briefly, and then we'll have to close.
Okay, I'll be very short. Yesterday, we found the body of one of our activist friends in Indonesia. His name was Rondi Januari. Rondi's body was found 2 days after he overdosed on heroin in one of us hotels in Bali. And the friend who was with him left him there, ran away, because he was so afraid to call the ambulance or call for help. Rondi and his friends bought the heroin at the prison in Bali, which is where a lot of the drugs are supplied. And as people would know, 2 of the prison heads have been fired in Bali for dealing with drugs. That points to several issues. Number one, that the trend in drugs continue to change. For a long time, Bali did not have heroin, and therefore a lot of the needle syringe program shut down because it was only amphetamines. But now heroin is coming back, and so we need to start looking at that. But the underlying problem is the fact that people are so criminalized that they can't even call for help when they need to save someone's life. That's important to recognize, that whenever we are talking about needle exchange and methadone, it's really critical in 1990s because we saw the infections go up so high. And we managed to bring down infections in several places. Eamonn and I was one of the designers of the National Harm Reduction Program in Malaysia in 2005-2006, and very happy that it went down 67% now. But what I also see is the rapid increase in men who have sex with men engaging in chemsex. And all of my friends who are gay in Malaysia can't come out to seek help because they're doubly criminalized, whether they are gay or they are gay men who are using drugs. So we're fighting for decriminalization because that is one of the key factors that drives people who use drugs to lose their health and their human rights, as it's written on the board over there. Health and human rights, every single international drug policies are about health, about keeping people's health and well-being. We're not safeguarding people's human rights if we don't respect the fact that people who use drugs have rights. Then we're not going to solve the problem of harm reduction. So congratulations, HRI, for bringing out this incredible report. I hope we'll go one step further in the future, all of us, in looking at criminalization and decriminalization of people for using and possessing drugs. Thank you.
Thanks, Palani. So I'll come back to the panel. If any panelists would like to make a short closing intervention, now is your chance. Yes,
thank you very much. And that all of the discussion today broadened my knowledge about the harm reduction. And because we have, in Thailand, we have to admit that the drug-free society is quite impossible, and how we have to live with it safely. Safe for the drug users themselves, and safe for the other people in the society too. That is, it's quite good thing for me that we have to manage the harm reduction in many ways. And thank you very much, and congratulations on the report too. Thank you.
Thank you, Kopkin Ka. Any others? Literally just very short. Bikas or?
I do have. Thank you for this last opportunity also. Just Palani, is the Rondi same Rondi? Because I was with one Rondi last week only, so. So yeah. So just wanted to say, there is no harm reduction without decriminalization. It cannot coexist in the same universe, same world, and enough of this mockery to these people, our friends and families who have been killed or who are dying due to overdose, and this is on those policymakers. This is on all of those. If you are here in this room, then it is on you that people are dying. And I just wanted to say that we need clear positions on decriminalization. Like UNODC is here. I have seen like UNODC's name in WHO's or some other's paper, like it's a joint paper, and then I would reach out to someone, but Karen, I would reach out to someone and I would ask, is this decriminalization UNODC's position? Then they would say, oh no, we just endorsed, but it's not our official position. And then in some other forum, again, same thing would be repeated, but yes, again, it would be kind of a joke to us. So we need that. Global Fund, UNODC, everyone needs to come up with this clear position. What do they want really? We all know what is there so much to lose. It's just ego that we have to lose, nothing else. Everything else, every life is going to be saved. There is a lot of like good things that is going to happen. The only bad thing that could happen is it would hurt your ego to accept that it's not going to be drug free. The world is always full of drugs, has been, will be. People will always use drugs. There will be always increasing number of drugs and drug users. And if we still do not care about these people, our friends and families, one day it's going to be one of your future generation, maybe children, grandchildren, or great-grandchildren, I don't know, but one of them will face this same situation. And so please, and the other thing was, I asked with Ann to give me a short moment. This was not the actual thing. So please come up with this clear positions on decriminalization. And the other thing was about the Nepal, the recent event that happened in Nepal, the rehab issue. So ANPUD, we have like translated the whole video into English and then made it in the form of a statement on the Human Rights Day on December 10. It's available on our website. So we tried to like make it an issue that would like create a momentum where these rehabs would start getting shut down. But it's so the nexus there is so difficult to reach, so life-threatening sometimes to deal with. So this is a very humble request as Bikas individual or ANPUD or a drug user who wants their friends and families to be saved in Nepal. So just a request that could we please come up with a statement on that issue. Every single detail is on ANPUD's website. What happened, everything is there. Just based on that, could you please, every organization who is present here, come up with one statement saying that these rehabs should be shut down, the monitoring should be taken forward. It's not just one rehab. There are more than 200 rehabs. It's just one rehab. We found out that they are detaining people who use drugs for 4 years and forcing them to lick their own urine and just beating them up. So please, can we do that, please? I would just follow everyone if the statement is there or not. Please.
Thanks, Bikas. Did you want to have 30 seconds, Eamonn?
30 seconds,
really
okay, all right. Well, it's only 3 quick things. So certainly decriminalization is critical as part of the prevention approach. For drug use, for sex work, for men who have sex with men, we've seen the benefits where it's been addressed and governments make the positive change. So it's critical that we address that. Fully support. Prevention, treatment, it's not either or, it's both. We can't be seen as pitting prevention against treatment. The same goes for PrEP. It's not either or, it's supposed to be a choice. I fully agree your points on choice, but we should arrange a panel to have a good debate on this issue. Final thing, is there a Michael in the room who doesn't have a wallet in their pocket? Because I know where the wallet is. Okay, thank you.
Cryptic. Yeah. And Katie has asked for 10 seconds.
Sorry, 10 seconds. So just on decriminalisation, in the report there are bits where countries have done that. There are a few. And there's one example that I can think of. I think it's Lithuania. You'd have to double check. It's in the chapter. Where they've decriminalised drugs and they've, instead of a criminal sanction for possession, you get a fine. But the fine is 186 times your salary. So decriminalisation really has to be functional. It has to work. It shouldn't be tokenistic, because the people can't pay the fines and they just go to prison. So the system is no different.
Thanks very much, Katie. And I think, you know, for many of us who've been working on drug policy reform for many years, we've really looked at many different models of decriminalisation, and that problem is one that is very clear, where there are other sanctions introduced instead of a criminal sanction. So it's really about removing punishment of any kind for people who use drugs, whether it's criminal or administrative or otherwise. So I think it's important to really try and be clear about what we're saying on that front. And maybe 2019 and the ministerial segment and, you know, the end of this 10-year period of the Global Action Plan is a moment to really coalesce the leadership around that, because we saw that going into the UNGAS in 2016. All the UN agencies that made submissions into the 2016 process made it very clear that criminal sanctions for people who use drugs was undermining their health, their human rights, and the achievement of the SDGs ultimately. So I think, you know, really trying to re-galvanize that leadership from within the UN system as well, to encourage member states to move away from criminalization. I think 2019 provides us with an important moment. One final thing. I know you're hiding at the back of the room, Inez, but I can see you. So we're very lucky to have with us Inez. Inez is one of the co-authors of the foreword of this excellent report from HRI, and Inez also has an excellent op-ed in today's Bangkok Post, which I encourage you to read, which kind of, calls on governments not to step away from harm reduction approaches. So just wanted to draw your attention to that, and also say hi to Inez at the back of the room. So, so thank you very much, everyone. Thank you to my excellent panelists. Congratulations again to Harm Reduction International for this fantastic contribution. And thank you to all of you for being here. Cheers, everyone.
Thank you.